Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, probably even the primary care physician, Dr. Paul Nelson Williams.
Yep, it's true, folks. I am a primary care physician. Matt, how are you?
I'm doing well. Paul, this was an asthma episode featuring Dr. Cyrus Askin, he's a homegrown pulmonologist, I would say.
Longtime team member, and then I just had occasion. I try not to listen to these if I can help it because I hate my own voice. But man, he did a good job with this episode. It's a really strong and comprehensive one.
And he has his own podcast, Critical Care Medicine now. Now, Paul, I heard that albuterol is dead. Can you please tell me about that? Because that's what I give to all my patients as first line. I tell them not to mess with any other asthma medications.
I am a little bit surprised you didn't do the famous Watto reversal where you just say the wrong thing explicitly and then have me correct you. But no, that's right. At least in regard to asthma, I think we've all seen and still probably continue to have a lot of patients who probably fall into what has been categorized as mild intermittent asthma. They have an albuterol inhaler that's been on their medication list for 20,000 years that they may or may not use. But that paradigm is supposed to have passed. We should have moved past that at this point, Matt. The new guidelines, and I say new guidelines, they've been around for over 5 years now at this point.
We covered this in 2019.
Yeah. It's so this idea of using SABA monotherapy is verboten. We should not be doing that anymore. The idea of leaving the airways unprotected from an inflammation standpoint is actually not great because the outcomes are not good. So what you want is a little bit of inhaled corticosteroid, Matt, to kind of reduce the inflammation while you're actually doing the bronchodilation as well. And usually that is done with ICS formoterol is the kind of going way. And we can talk about whether or not we're using that solely as rescue medication or as a controller or as both, all of which are okay. But you want to have the inhaled corticosteroid there as sort of background stuff because just a SABA monotherapy, actually those patients just don't do as well. They end up with worse exacerbations and more hospitalizations.
For our audience who's old like me, I mean, you're going to want that cowbell. Inhaled corticosteroids in this case are the cowbell. You're going to want that cowbell. So ICS LABA is like long-acting beta-agonists. Formoterol is the one that is prioritized because it has that quick onset of action. And Paul, there is an inhaled corticosteroid. Budesonide is commonly paired with formoterol, and then there's also, it's been advertised recently, there's budesonide with albuterol. So it's budesonide with a short-acting beta-agonist. So I've noticed that that's on some formularies, and we asked Dr. Askin about that, and he prefers the long-acting beta-agonist, the formoterol, to be the paired with the steroid. But in some cases, patients are gonna only have access to the albuterol with inhaled steroid. So I guess having some inhaled steroid or cowbell, using my terrible analogy, is is better than none.
And he even gave us very hesitant permission in extreme circumstances to have an inhaled corticosteroid plus albuterol as needed as your rescue inhaler. But you want that inhaled corticosteroid in there as your base note.
Yeah, and in my experience, it's like the inhaled corticosteroids by themselves are not that cheap compared to like the combination therapy, so it almost doesn't make sense. But I know what you mean. Like there are some patients that they just can't afford the formoterol containing formulation, so you kind of just are stuck there. All right. Well, Paul, I heard there's some non-pharmacologic things that we can do for asthma. Do you have any favorites there?
Yeah, I loved a lot of points that Dr. Askin made at the end of the episode is when we started talking about this. But he talked specifically about how exercise is a potential trigger. He doesn't even use the term exercise-induced asthma because he feels like that gives a signal to patients that they should stop exercising then. It actually turns out that patients do better when they exercise in almost every circumstance. So instead, he actually talks about exertion as a potential asthma trigger as opposed to this exercise-induced asthma. And you treat the asthma appropriately, and the patient should still be encouraged to exercise because they'll do better overall. And we spend a fair amount of time talking about weight loss. Patients with obesity have harder to control asthma, I think more frequent exacerbations, if I remember correctly. And he, even in his pulmonology clinic, he will have conversations about medications for weight loss and therapeutic lifestyle changes and those kind of things. And then, we're presumably talking to a largely primary care audience, doing the thing we're supposed to be doing anyway, vaccinating against viruses, so making sure COVID and influenza and pneumococcal vaccinations are all up to date and really protecting our patients against potential infectious triggers as best we're able to as well. So I thought that was a nice reminder we should be doing that all the time, but especially with our patients living with asthma, it's really important to be diligent about being able to protect them in that way.
And to go jump back to the diagnosis, on previous episodes, we had previous guests who weren't that into spirometry. However, the guidelines and Dr. Askin were favoring doing spirometry in patients. I guess if you're in a very resource limited setting and someone has a very classic presentation of asthma, treating them and then sorting out later is probably okay to do. But for most patients, if you're in a well-resourced setting, getting spirometry is the way to go. And if the person has no symptoms at the time you're getting spirometry, it may be normal. So Dr. Askin says in those cases, he might go right to spirometry with methacholine, where they're getting escalating doses of methacholine to try to induce some obstruction that you can detect on the test. And then you would do the bronchodilator challenge after that to see if you can reverse the airway obstruction, because that's what you need to make the diagnosis of asthma. And in some cases, Paul, you can even use peak expiratory flow to diagnose asthma, I guess, again, if you're in resource-limited settings. But that's not something I've done before.
No, it's every place I've practiced, both rural and urban, have had fairly easy access in a relative way to pulmonary function testing, which I have not seen done as consistently as it probably should be for our patients with asthma or presumed asthma.
This was a fantastic episode, and if you want to hear the full episode, you can click on the link in the transcript below. And with all that, until next time, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
And we'll just let you sit with that for a second, and I remain Dr. Paul Nelson Williams. Thank you, and goodbye.